Assalamualaikum dear doctor. In this video I am discussing a video station. So first we will watch the video, then I will discuss what type of question we are expecting from this video station. So first question is that what I observe in this video, I can see a 1-year-old child who is on hospital setting. The child has no any obvious dysmorphic features. There is I see that the child has generalized tonic-clonic seizure which is involved both the upper limb and the lower limb. The child has also eye blinking, facial twitching, lip smacking. So this is a generalized tonic-clonic seizure, and my on top diagnosis is meningitis. And differential diagnosis, it could be encephalitis, it could be dyselectrolytemia, it could be any metabolic complications. And if there is rash anything, also differential diagnosis, it can be sepsis, DIC, leukemia, hemolytic uremic syndrome, ITP, HSP, COVID, and PIMS, that is blanchable. So if rash and everything, also seizure associated with this disease. Now what history would like to ask in this patient? So for meningitis we can ask the onset, course and durations. Is that associated with any fever, the child consciousness level, and any fits, neck stiffness, irritability. Also child diet habit, when last he has taken, because hypoglycemia can be one of the cause. We also ask that how long he is suffering, because febrile convulsion we can be exclude. Family history of any similar conditions, because we know febrile convulsion is an autosomal dominant conditions. Is that fast attack or recurrent attack, any associated with infections like UTI, ear infection, anything present or not. So this history we will be asked in meningitis. Now what examination we would like to do? So the examination we would like to do for meningitis is that admission, isolation, notification, examination under complete aseptic measure, wearing PPE. ABC, airway, breathing and circulation, hydration status. GCS normal is 15 and comatose patient is less than 8. Best motor response we give 6, best verbal response give 5, and 4 for spontaneous eye opening. Neurological examination with Karnick sign, painful knee extension, and Brudzinski sign, neck flexion and knee flexion, and a glass test for non-blanchable rash. So these are the examination we will do. Now investigation. What investigation we can do? These are number 1, full sepsis screening, full blood count, urea and electrolyte, lactate, LDH, CRP, blood gases, blood cultures, urine culture, and serology. Also we can do the fundus examination, lumbar puncture within 1 hour or arrival in hospital, CT and MRI brain. Contraindication to lumbar puncture. What are the contraindications of lumbar puncture? These are GCS is less than 9. If GCS less than or equal to 12, discuss with the consultant. Then shock, respiratory insufficiency, continuous or uncontrolled seizure, focal neurological signs, infection at LP site, coagulopathy known or suspected, or platelet less than 40. If not, don't delay LP for results. Papilloedema, do not delay LP if fundi cannot be seen. So these are the contraindications of LP. Now about the management. Suppose this is a meningitis. Management is first notifiable disease. So notify if it is included in notifiable disease. Steroid. If age is more than 3 months and less than or equal to 12 hours from start antibiotics. TB not suspected unless on TB treatment. A&D LP shows frankly purulent CSF. CSF WBC more than 1000 per microliter. Raised CSF WBC protein more than 1 gram per liter. Bacteria on gram stain. Antibiotic within 1 hour of arrival in hospital. Cefotaxime or ceftriaxone in high dose. If age less than 3 months, add amoxicillin IV high dose. If recently overseas or prolonged or multiple antibiotic exposure over the last 3 months, add vancomycin. If focal neurology or seizure or reduced Glasgow Coma scale, add acyclovir CNS dose. If there is a definite history of anaphylaxis to penicillin, give chloramphenicol. Now the duration of treatment is that meningococci we give 7 days, Haemophilus influenza we give 10 days, pneumococcus and group B streptococcus we give 14 days, and listeria and gram negative we give the 21 days. Fluid restriction. Normal saline plus glucose 5% plus potassium chloride 10 mg per kg. Restriction to 80% if severe illness, hyponatremia and raised ICP. Measure urine and plasma osmolarity daily for risk of SIATH. If the patient has not improved, repeat culture, CT at 10 days. If CT is normal, repeat LP. Prophylaxis by Public Health Authority. Meningococcal meningitis, ciprofloxacin single dose for all ages. Haemophilus influenza, rifampicin once daily for 4 days. For close contact less than 10 years. Pneumococcal, no prophylaxis. Follow-up. Follow-up is hearing and developmental assessment. We know that sensory neural hearing loss is one of the complications of meningitis. So this is all about meningitis video station. Please do subscribe and share MRCPCH with Dr. Emma Chaudhary. Thank you.